Okay, Mr. Rami.
Listen to our talks today. So I'm Chris Pryor. I'm one of the orthopedic consultants at Alder here. My special interests are major trauma, complex trauma, and limb reconstruction. And today I would like to present to you some of our thoughts on how we treat femur fractures, concentrating mostly on femoral shaft fractures. So all fractures should be treated in the way of respecting contact, alignment, stability, and stimulation, and biological factors to enable healing. However, in children, we know that they're not just small adults, they're biologically different. So your parameters for accepting the amount of contact, alignment, and stability may change. And the femur fractures are a perfect example of this. So take this fracture, for example. This is an 18-month-old who came in with her parents with a fractured limb. For me, the first and most important thing to discover is if there are any concerns about the story. So taking the history is extremely important. And one thing we want to make sure is that there aren't anything to suggest that this is a non-accidental injury. And Ms. Bucknell will talk further about this later in the talk. So young children with femoral fractures can be managed in a variety of different ways. When children are very young, because the biological healing rate is so quick, they only really need to be immobilized in a reasonable amount of contact and alignment for it to heal. So if you have a baby that's less than 6 months old, it would be reasonable to consider using this, a Pavlik harness. So as you can see, the straps anteriorly prevent hip extension, the posterior straps prevent hip adduction. If you have a slightly older child, up to 18 months or even up to 15 kilograms, then this is gallows traction. This is another non-operative way of managing femoral fractures. And they do very well, but obviously they need special care and attention, which we'll come on to. And there are other ways of treating babies and children without having to do open operations. This is gallows traction. So the principles of gallows traction are to give counter traction to the limbs. And to set this up, you need to have bars above the baby. You need to have the bottom raised off the bed so that the weight of the baby pulls the counter traction onto the limbs. And you need to ensure safely that the ropes are nowhere near the child so that they don't come to any harm. So if you want to know how long a fracture is going to heal in a child, our rough rule of thumb is to have their age in years and add 2 weeks. So that's how many weeks it would be. So for an 18-month, it would be roughly 3 or 4 weeks of healing. Here is how you can set up traction. So certainly in Alder here, this is the typical setup for a child under the age of 5 who has a femoral fracture. This is a Thomas splint, and the principles are that it will give you alignment and you have traction within the splint. You do counter traction so that the splint doesn't cause a pressure area. So the bed has to be tilted so that the patient doesn't slide down the bed. But if you do not have a Thomas splint available in your unit, this is Hamilton-Russell traction. So it's a principle of skin traction without having to use an external device. This is a hip spiker. So hip spiker is plaster immobilization of the femur. So of course, the principles of immobilizing any fracture are that you have to immobilize the joint above and below. So that includes both hips at the same time. It's important that you immobilize the ankle as well, because the pull of gastrocnemius may displace the fracture as well. Now, you note that this particular type of spiker cast may look different to the type of cast you've seen for DDH, for example. So why is that? Well, there is a good paper by Dr. Mubarak, who discovered that if you do so-called 90-90 traction, whereby you reduce the fracture by putting a cast on and pulling the patient's limb outwards, you can cause a pressure area behind the calf. And he showed a case series of complications with ischemic contractures, pressure areas. So for femoral fractures, we recommend that you put them into what we call the Harley-Davidson position, which is like sitting on an inclined motorbike. So you put the hips out to length, you mold the cast around the fracture so you get your alignment without having to do too much in the way of counter traction, and then you put the cast around there. What do we do with older children? You have different options for older children. You can always use traction. However, you may have factors that mean that you don't want to keep them in hospital or at home in a splint for a long period of time. So if you have a 7-year-old with a high energy injury like this one that has comminution, if you put them into a splint, it's going to take at least 9 weeks of traction. So in our experience, we would consider doing operative treatment. And the three main operative managements of femoral fractures in this age group are flexible nailing, plating, and external fixation. They obviously have their pros and cons, the least invasive being flexible nailing. But in order to use flexible nailing, you must ensure that the fracture is length stable and is in the diaphysis of the femur. We'll talk about that further. Plating obviously carries implications of scarring and having to move the plate further down the line. External fixation obviously has to have pin site care, and there are studies that show that they have a high rate of refracture after removing the external fixation as well. So nailing a femur is a bit of an art and requires some technique tips that I'm going to give you now. So the first thing you need to do is decide the width of the nail. In order to do that, you should use your radiographs to measure the internal diameter of the femur. When you measure that, you divide it by 3, and that should roughly be the diameter of the nail. So somewhere between 30 to 40% of the diameter of the internal cortex. When you've positioned the patient, the entry point for the nail, we would use a trocar device, and you start at 90 degrees to the bone, and then the trocar needs to be put at 45 degrees at the bone, and your entry point must be away from the physis. So we would recommend about 1.5 to 2 centimeters away from the physis. Before you pass the nail up, you need to pre-bend it. Why is that? Well, that's because the nails have hoop stresses at the fracture site. So you put your nails over the patient, you take an x-ray to see where the fracture site is, and you take both nails and bend them together so that the bending is in the same place. Otherwise, it will displace the fracture. Now, how much bending do you do? Well, again, you use the internal diameter of the femur and you multiply that by 3, and that should be the curvature, the radial curvature of the amount of bending. And this is the technique. So you pass, we pass them retrograde, we pass them simultaneously if possible, or incrementally, past the fracture site. And then because of the way the instrument is cut, we leave it proud, and then we push it in, we tap it in afterwards. So make sure that you leave a sufficient gap to allow that to occur. If you want to push the boundaries of how much you can use flexible nailing, there is another device on the market called an end cap, and this will allow a certain amount of compressive forces through the nails. So that can be selected in certain individuals. Another tip: when you've picked your entry point, we usually pass a drill across so that the entry points are at the same site. And here's an example of how we pass things sequentially up. And here's what a typical one. That first one was an open fracture, so we debrided before we passed the nails. Who is not suitable for a flexible nailing? Well, if you look at the evidence, there was a large multi-center study that concluded that for a typical flexible nailing technique, children over the age of 11 and over 49 kilograms tended to fail. So we would recommend that if they're under 12 or under 50 kilograms, they would be suitable for flexible nailing. So here's an example of a patient who has diabetes, and that's what this device is. It's a pump, who fell off a bike, and they had what you might consider a non-length stable fracture. If you look carefully, there's a bit of extension there as well. But because it was mid-diaphyseal, because the patient was 8 years old, a colleague of mine thought it'd be reasonable to try flexible nailing and using the end cap technique. So this is what it looked like in theatre, and this is what the end cap looks like, so that the nail sits inside there. And unfortunately, it did displace, and that is in keeping with the literature that if they are length unstable, they have a higher likelihood of displacing. So they went on to have a open reduction, internal fixation with a submuscular technique proximally and distally. So what do I do? So this is an example of a 5-year-old. So that's the kind of borderline where we would have a conversation with the parents to see what they want to do. And in this case is a child who had parents who lived far away from the hospital. It was near to Christmas. They wanted to be home. The parents were self-employed and couldn't take time off work, and they wanted a faster way of getting the child back on their feet. So I did a submuscular technique. They use a relatively small incision distally and proximally underneath the vastus lateralis with scissors, pre-bent. This is a large frag plate. You can use small frag that's narrow, and this is just to show it doesn't need to be a perfect reduction. Okay, so you can see that it was the length and rotation were correct. So there's a little bit of flexion, but this is only 6 weeks down the line, and the patient was fully weight bearing in the clinic, so they heal incredibly quickly. So you can get good results there, but again, that is a conversation you need to have with the parents. So what do you do in older age groups? So when you get to about 12 years old, that's when we would consider using something solid. Why don't you use solid nails when they're younger? Well, we worry about the risk of causing avascular necrosis of the femoral head. So this is a device, this is a lateral entry nail. So the worry is if you put your a piriformis entry nail in here, it has a higher risk of avascular necrosis. I believe that if you use a tip entry nail, it's relatively safe. I think the literature is mixed on this about whether it's safe. You should be using lateral entry nails or not. My concerns, or what you should be concerned about when you're passing one, is that because the entry point is quite lateral, first of all, when the nail is passed down, you need to be careful that you don't blow out the medial cortex. And secondly, when you pass it, when this part of the nail enters, you can knock off the greatest cancer. So just be wary about that, and you may have to consider over-reaming. So this is a brief summary of how we treat diaphyseal femoral fractures in different age groups. I'll briefly talk about neck of femur fractures. So they're usually relatively high energy injuries. The key for children is that they need to have anatomical reduction, and they need to be stabilized as well. So these can't be treated with traction. The controversy exists about whether you should do something to reduce the pressure of the capsule because there's bleeding there. So we typically do that, we release it, but the evidence is mixed on this. But what are we worried about? We're worried about the high risk of avascular necrosis, particular in the more proximal fractures. So I just want to point out that although we might be scared at times of crossing the growth plate, the femoral physis, it's really important to get that stability. So in this case, I would pass it over the physis and plan to remove the screws when it's healed. So this is a nightmare. This is something we really don't like to see, a high energy injury of the distal femoral physis. So they tend to be high energy injuries. They're analogous to a knee dislocation. First and foremost, you need to be careful of any neurovascular injuries. So this is a patient that had a closed reduction, KY fixation. These wires will need to be in for at least 6 weeks, possibly longer. So if anything is going to be in for longer than 4 weeks, we would bury them. But what are you most concerned about after the initial trauma? We are worried about this. This is a growth arrest or growth disturbance. So the physis has stopped growing on the lateral aspect and it continues to grow here. So this child was young enough to know that they're young enough that they're going to go on to a further deformity. Whenever you see a bar, ask yourself, where is it? How big is the bar? What will happen if I leave it? And how much longer are they going to grow for? So further imaging will help you decide where it is and how big it is. This is roughly an algorithm of what I would ask you to think about. So if you find a physeal bar and they have an angular deformity, your options are that you can either stop growth and correct the angulation, or you can excise the bar. You need to stop it from getting worse by putting an 8 plate on as a hemi-epiphyseodysis. However, if they have a limb length difference, then you need to ask yourself, what would happen if I do nothing? You might have to think about stopping growth on the other side by performing an epiphyseodysis. Or if you think they've got sufficient growth remaining, you might consider a bar excision. Any of these scenarios, if you're left with a limb length discrepancy, you may need to consider a lengthening procedure at the end of growth. So briefly, just to mention, if this is what a bar excision looks like, there are lots of techniques out there. This is the Langen-Scale technique. The bony bridge over the physis needs to be removed and you need to stop it from growing back. So here's one that we did using a low-power drill. This is the 8 plate to stop it from getting worse. And then we put fat graft in with clips and some cement to stop this from coming out again. Okay, really, just to summarize, whenever you have femoral fractures in younger children, always consider non-accidental injury. Most femoral fractures can easily be managed non-operatively, just need time and the skill. Be very careful about spica casts in the 90-90 position, and always think about the stability of your femoral fracture if you're considering flexible nailing, and particularly in older and larger children. Intracapsular fractures need an anatomical reduction, and you must monitor distal femoral fractures for a growth disturbance. Thank you very much.
Thank you so much, Mr. Chris, for this very interesting and illustrative talk. Thank you so much, sir. Mr. Rami, you are the moderator with Mr. Chris. You are muted, Mr. Rami.
Yes. Thank you, Mr. Pryor, for your brilliant talk. I have received a few questions about the femoral fracture. The first one is about the timing for surgical intervention. When do you decide to take the patient for theater for early spica or delayed spica?
Good question. So if I think that it's a minimally displaced or a length stable injury, I will take them earlier for a spica cast. If I want to use a spica cast but it's length unstable, I put them on traction for about a week and then I bring them to theatre, because I don't want to rely on the cast to keep the length stability. But of course, remember that you can accept a small amount of shortening because they will get overgrowth.
Oh, brilliant. Thank you very much. There is a question from Mr. Abdelhail. He is asking about the evolution of elastic stable nails and the strategy of dealing with femur fracture in early childhood. Do you always decide for tense for elastic nail according to the patient age and weight, or there is another criteria for this type of fixation?
Yes, so I maybe didn't make it as clear. So first of all, length stability. If I think that the femur will shorten, if it's an oblique fracture, I won't use a flexible nail. If it's a short oblique, I might use a flexible nail with end caps. If the fracture is very proximal or very distal, i.e. in the metaphysis or the proximally or distally, I think that a nail will fail. And in those circumstances, I will use a submuscular plate.
Brilliant. Thank you very much. There is a question about femur fracture, and what is your preferred technique of closed reduction to reduce the displaced femur fracture?
Okay, so they're relatively rare events, thankfully, but whenever I've seen them, so there is the Ledbetter maneuver. So that's where you do traction, internal rotation, you let the capsule relax, then you bring the limb into external rotation and then extension. However, most times you need to open it. So it's your personal choice as to your approach. You could use an anterior approach or a Smith-Peterson approach to make sure that you can visualize and see the femoral neck. It allows you to decompress the capsule, and then you can pass your guide wires and then your cannulated screws over them.
Okay, thank you very much.
Mr. Freyer, may I have a question from myself, please?
Sure.
Sometimes in subtrochanteric fractures, we use the elastic stable nailing, but we usually use 3 nails because the deforming forces in this area is much higher. Do you accept that, sir? Is it acceptable for you, or you don't prefer to use this technique, sir?
So like anything else, I go just on my own experience, and I've seen examples of that, and it's certainly had good results. My own experience is only using retrograde wires. I have seen antigrade wires as well. If you feel that you can get good stability with it, then that's fine. I just quite like the submuscular technique. It allows me to know that the patient is going to be able to weight bear. I start them with 30% weight bearing, and if they're completely length stable, they can weight bear as much as tolerated with crutches. If I'm worried at all about the stability, I start with 30% weight bearing until I see callus. If I'm using a flexible nail, I'm a little bit more cautious about it, but it's certainly acceptable.
Thank you, sir. Mr. Rami, any questions?
Thank you very much. There is one question about the timing of femur fracture surgery. Is it overnight surgery or the next available list?
So I think the crux of it is you need to get a good reduction. And for what it's worth, I know I'm going to do a better job the next morning. So if it's in the middle of the night, but I know I've got an available list the next morning, I would leave it until the next morning. And I think my colleagues would be the same.
Okay, brilliant. Thank you very much. Mr. Al-Ahmadi asking about conservative treatment with femur fracture. So in case of multiple trauma child injuries, what is your type of fixation for DCO?
Yeah, good question again. So I think that certainly external fixation has its role for this, because you want, in damage control surgery, you need to get something on quickly, and we would do that. I know I mentioned about the risks associated, but sometimes you have to do it. There's increasing evidence now that it used to be that the dogma was that you can't do a nailing within 7 days of a external fixation, but there's more evidence now that you can do that even further down the line if you're concerned. We also have another technique that we use in Liverpool, more for our elective lengthenings, that we do a medial submuscular plating to reduce the time of requirement for the external fixator. But yeah, in damage control, absolutely. But again, if it's a length stable, then flexible nailing's just as good if you're quick enough.
Brilliant. Thank you very much. No more question for me, please. Thank you.
Thank you so much, Mr. Chris Prayer, for this very valuable presentation. Thank you so much, sir.
Pleasure.
Hoping to see you again in our course. Thank you so much, sir. Now we will